So today's webinar is called Soteria Houses, Safe, Humane, Life-Enhancing Treatment for Psychosis. It's part of our Compassionate Approaches to Crisis series. And our panelists who are going to introduce themselves very soon are Al Galves, Eugene Larkin, Susan Musante, Nico Oldfield, and Katie Bork. And I am Shira Collings. I'm the grant coordinator for the National Empowerment Center. This webinar was developed in part under grant number SM082648 from the Substance Abuse and Mental Health Services Administration, U.S. Department of Health and Human Services. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. This webinar will be recorded, and the recording will be posted to the National Empowerment website at power2u.org. So please do feel free to turn off your camera if you don't wish to be on that recording. And closed captioning is available. Click on the CC or more to view closed captioning. You can also view the entire transcript of the meeting by clicking on Show Transcript. And at the end of the webinar, there will be a Q&A session. You're invited to ask questions at any time through the chat function. We generally cannot answer all of the questions, but we will do our best to answer them all. If we don't answer your question, you are welcome to email us at info4@power2u.org, and we'll do our best to get back to you. And you're also welcome to make comments using the chat function. And I'm going to stop sharing, and I will now turn it over to our panelists to introduce themselves. I'm really looking forward to this webinar, and thank you for being here, and I'll turn it over.
Okay, thanks. Thanks, Shira. Hi, everyone. Good morning and good afternoon. It's great to have you here. We're going to be talking about Soteria houses, what they are, how they work, why they work maybe, and kind of what happens in them. Get an idea of the flavor of them, how it goes, how the treatment in Soteria houses goes. So I'm a psychologist in Las Cruces, New Mexico. And, you know, when I was studying to be a psychologist, I was daunted by the idea of psychosis. You know, I say, well, what am I going to do? Here are people who are experiencing extreme states, and maybe hearing voices, believing things that other people don't believe, seeing things other people don't see, maybe in some ways being disorganized. And so I kind of wondered, well, what am I going to do? Is there something I could say maybe in a session, or some interpretation, or what would I do? Of course, one of the things I could have done was say, well, it's going to be the relationship, but that's going to take a long time. Do I have enough time to develop a relationship? So then I learned about Soteria houses, and it was like an epiphany. It was like, oh my God, this is how to do it. This is the way to do it. This is the way to help people who are in this experience. And there are lots of ways. There are many ways to help people. This is one, I understand that. But this, I think, is a very good one. So I'm glad you're here. We're going to talk about Soteria houses. So Soteria houses are home-like residences. The ones I know of, all of them have had like between 5 and 8 beds. And so they're home-like residences, and people who are experiencing psychosis come to them, and they live there. And they are provided with safety, support, and affirmation as they go through the experience. There's no effort to get them back to where they were, or to stop whatever's going on with them. The idea is we're going to help you go through this experience, because even though it's impairing in some ways, and it may be scary and agitating and upsetting, somehow it's how you're surviving. It's how you're moving towards healing and recovery. So we're going to help you do that. And typically in Soteria houses, people stabilize within 6 to 8 weeks. They become somewhat more stable. And when that happens, they're encouraged and helped to go out into the community, take a class, get a job, volunteer work, supportive employment, go to therapy, go to support groups, um, art, recreation, church, somehow helped and encouraged to get back into the world. Um, so what else can I tell you? They are largely staffed by peers, by non-credentialed people. Many Soteria houses are led by licensed clinicians, but not necessarily. Some of them are led by people who have had experience, a lived experience, who are recovered, who are peers, have been trained. So that's kind of something about the staffing. All of the Soteria houses I know of have had a contract or a connection with a psychiatrist, so that psychiatric medication is available on a voluntary basis. But it's definitely voluntary, and it's not the primary modality of treatment. The primary modality of treatment is relationship. So why do we think this works? Is there any evidence that this is an effective treatment? Well, there's unfortunately, there's really only one good study, I would say, good study that a hard scientist would accept. There's other evidence, but there's this one good study, and it was done at the original Soteria House. Now, the original Soteria House was located in San Jose, California, and operated from 1971 to 1983. It was the brainchild of the psychiatrist who was the head of the National Institute of Mental Health's Schizophrenia Research Project. His name was Loren Mosier. And he wanted to demonstrate or see if this would work as a treatment for psychosis. So he created the Soteria House. And since it was a research project of the NIMH, a very good study was done. So patients, and I have to clarify something, that the original Soteria House was designed for people in first break, in their first episode of psychosis. So patients were randomly assigned to Soteria or to the hospital for treatment, the hospital with conventional treatment focusing on drugs. 2 years after treatment ended, researchers went and interviewed the patients. And what they found was that the patients treated at Soteria were doing significantly better in terms of social functioning, where they lived, who they lived with, how independent they were, employment, the kind of employment they had, less rehospitalizations, and less symptoms. So it was effective. This research project showed that Soteria was an effective treatment for psychosis. But instead of replicating it, instead of seeing if it might work in other settings, maybe trying it out in a hospital ward, the NIMH shut it down, fired Loren Mosier, and buried the data. Buried the data. Now, the reason I know that data was buried is because I sat down with the woman who was the head of the NIMH's schizophrenia research project in 2010, and I asked her, have you ever heard of the Soteria project? No, never heard of it. And Robert Heinsohn, the psychiatrist at NIMH, who really started the first episode psychosis programs, he'd never heard of it either. So that's what happened. It was buried. The data was buried. So since then, there have been Soteria houses. There's one in Bern, Switzerland, that's been operating since 1978. There have been Soteria houses in Europe. There are 3 of them in Germany now. One is being created in Belgium. In the United Kingdom, the National Health Service is doing a year-long study to see if they want to have Soterias be part of their standard of care. There are 4 Soteria houses in Jerusalem. It is the standard of care in Israel, being paid for by the Ministry of Health. There was a Soteria house in Alaska, operated from 2009 to 2015. And there is one today in Burlington, Vermont, that's been operating for 10 years, very successfully. So that's kind of the story of what's happened. So let me let me just give you a few other ideas here. Let me share my screen for a second here and give you a few other okay, I have a little trouble starting the slideshow. Okay, can you see that? Can people see that? Okay, that's just what basically what I just went over. Um, some idea about how Soteria houses work. You can read that. Can everybody read that? If anybody can't read it, I'll say it. I'd rather not do that. Here's a citation. This is the citation for the article that was published in a peer-reviewed journal reporting on the study that I told you about. And so the next couple of slides give you a little more information about how people recover. So Dr. Moser, Lauren Moser, and Boyce Hendricks, who was the house manager for 8 years at the original Soteria house, they wrote a book called Soteria, From Madness to Deliverance. It's a terrific book. If you read that book, you get a pretty good idea about how it works, what happens, why it works. So they, in the process of writing that book, they talked a little bit about how they thought people recovered. And here is what they thought. Basically, they thought mainly the way people recovered, and of course, people recover in different ways. And you'll hear about all the different ways people can recover. And of course, you know about that. But they thought that in some ways there was in some ways a generality about how people recovered, and it was really about through developing relationships. So you can read this slide. Okay, so that's my introduction. And what we're going to do now, we're going to open it up. And we're just going to open it up and let our panelists contribute as they will, as they want to contribute. I think what will happen is you'll begin to hear some stories about what happens at Soteria houses, get some idea of the flavor of, and of course, you know, I'm making it sound a lot too much like Sweetness and Light. As you can imagine, there's a lot of emergency, crisis, chaos, all kinds of weird stuff that occurs at Soteria houses. So you'll maybe get some flavor of that. So our panelists are Gene Larkin. Gene volunteered at the original Soteria house in San Jose, California. He then became a member of the staff and then was the director of a replication of Soteria called Emanon in San Jose. So Gene really had a lot of different experience, quite a lot of experience with the original Soteria houses. Susan Musanti is with us, and I'll let these people introduce themselves more if they want to do that. Susan Musanti is with us. She's the co-founder and was the executive director of Soteria Alaska from 2007 to 2015, I think, around in there. Katie Bork is with us. She has been the executive director of Soteria Vermont, has been really with Soteria Vermont since its inception, I think probably in 10 years ago, and still has responsibility for the operation of Soteria Vermont. And then also with us is Nico Oldfield, and perhaps he can introduce himself when he contributes, or Katie maybe can introduce him. So I would encourage all of you to put questions into the chat as they come up. Shira is going to monitor the chat, and Shira she can intervene with a question that seems to be at an opportune time, and we'll just take the questions as they come up. So the floor is open. Fellow panel, the floor is open.
I thought it might be interesting to read just a couple of sentences that were written by Lauren Mosher, who Al already talked about. So Lauren Mosher and Elma Min wrote a report to the NIMH, which had funded their Soteria project. And in the beginning, I think this was partially the motivation. They say schizophrenia, this was out of the early 70s. Schizophrenia remains our most recalcitrant mental health problem. Its scope is reflected in the disappointingly low levels of psychosocial functioning achieved by 65 to 85% of discharged patients. Their high readmission rates, which are 50%-ish, and the relatively large population of currently hospitalized patients. In revealing the inadequacies of our present treatment of schizophrenia, these figures serve as powerful justification for continued innovation in conceptualization and delivery of services to this population. I wanted to read this because as I was getting prepared a little bit for this, it struck me that our system, our conventional system, is not that different from what they described in the early 70s. So we haven't come along very far, and we haven't actually implemented fully approaches such as a Soteria approach. So I wanted to do that. And I did want to say that there are a couple, there's more than a couple, but there's some notable studies. But one in Finland had an 80% success rate with people who carry that label of schizophrenia. And the other was a Soteria 10-year study that Al referenced. And that demonstrated high rates of recovery for many without the use of medication or minimal medication. So this is justification of why hopefully more people, more organizations will begin to think about implementing the Soteria and similar approaches. I just thought I'd start with that.
Thank you so much, Susan. We do have a question in the chat asking about anosognosia. I hope I'm pronouncing that correctly. A diagnosis of schizophrenia often involves anosognosia. My son has this issue. How do you reach out to those with anosognosia to assist in their care?
Can I respond to that? Anecdotes is, I'm going to try and say this politically correctly, is a made-up thing. It's where they say people don't believe or understand or are in denial that they have a mental illness. And there's no research that I can ever find. It's been descriptive. It's descriptive perhaps, but there's no research that is evidence that there's actually that. Now, that being said, a lot of the people that I personally know who have good recovery in with these serious diagnoses of psychosis actually benefit from what you would call anagnosia, because they want to go forward. They don't want to be sick. So that's my personal take on it. I don't know, Jean, you got any thoughts on that one?
Well, I'm probably much broader. I don't think there's such a thing as schizophrenia. I think these are just descriptions of behaviors. And you can combine any number of colors and make whatever picture you want. And so they just list, it's a list of behaviors that people find threatening. And then they put them in these little boxes and put names on them, and then they think that's proof that that's a mental illness. I think that is incredible BS. At both the Soteria houses I worked at, and I'm guessing with you in Alaska and Nico and Katie in Vermont, you don't even you aren't spending time looking at schizophrenics because they don't exist. They're not there. What you're spending time is looking at human beings. And I saw somewhere when people were signing in, I just saw the term emotional anguish. And I think that is a much better description. Now you can put a name on it. I don't care if you want to call it automatopoeia, but it's emotional anguish. It's emotional pain. And the difference is in that what I know what Soteria houses do, and what we did was you treat them as human beings. You immediately reach out to them as a human being in need of help. The first thing you do is not to label them, not to put them down by telling them they're wrong, not to denigrate them by telling them they're ill, mentally ill, that there's nothing they can do about it. It's some kind of catastrophic disease that's been laid on them. You just take their hand and say, you look like you're in a lot of pain. How can I help you? And what you're doing is saying, you're a human being the same as me, and I'm not making you separate from me. And I think that's the terrible sin, the mortal sin of what the mental health system does. It puts these labels on these people and then immediately makes them other than me. I'm always better than you because you're mentally ill and I'm mentally healthy and I can help you, but you can't help me. And that is just so incredible much BS that instead of just saying, what can I do? We're both here together, sitting at this table. What can I do? I can just listen, or I can talk, or we can play chess, or we can play checkers, whatever. And that to me, that's the difference. Go ahead.
I do think that Deborah's question is getting at something important in addition to what you all have named that we haven't quite talked about yet, which is that there is, I think, often a real distance between what a person in crisis might be self-identifying versus what the people around them might be identifying about their experience. And of course, we want to prioritize people being able to define their own experiences for them. And so that's not what I'm suggesting. But like, I think some of the most powerful work that we do at Soteria, in my opinion, is and some of what it means to me to stay in community is not just like a literal location and also not just like having relationships, but also being able to talk really openly about experiences that people are having. And that some of the most transformative work that I've gotten to participate in with people is when I can really name that I'm experiencing something that the person I'm talking to is not identifying that they're experiencing, but it's happening in some form. We can figure out how to define it together. But I think there's a way that, like, while we are not setting out on a goal to return to a pre-crisis state or make crisis features disappear or whatever, there's something about being able to be transparent and being able to name what I am observing or experiencing with someone that can serve sort of as a tether to community, and a tether to the parts of shared reality that we're all interested in continuing to be a part of. And that I think one of the most powerful things about Soteria houses is that, like, the way we can approach those differences in perception or experience is without judgment, but it's not that we are sort of like pretending like that isn't happening. we get to talk really openly and non-judgmentally about whatever it is that I think might be going on that somebody else might not be able to speak to, and then they get to speak to it. And I think over time, and definitely through the vehicle of relationship, is where we can actually like make some progress there. And especially if we're able to do it in a way that's not like a battle for the truth, or a battle for defining reality, but it's just like we're obviously coming from different places right now, and I would like for us to like understand each other as best as we can. And yeah, maybe I'll just leave it there.
I'm gonna let Katie, because she looks like she wants to say something, but you just triggered something. I worked with someone who had a really nice way of doing what you're just talking about, Nico. And he would say, I'm not sure I'm understanding what you're saying. Can you say it in a way that I can understand it better? And kind of put it on himself, not on the person, not like you're talking in a way that's not judgmentally. It's like, help me understand because I don't get it. So I'm sorry. Katie, you got something you want to say on this topic?
I think, yeah, I'd echo what Nico was saying too. I think one of the frameworks that we talk about this is like internal and external worlds and how sometimes those don't always align. So we're able to offer people reflections on like how they might be presenting to us externally and like be curious about what that internal experience looks like for folks. So I think that's one framework for me that's been really helpful and how I kind of converse around that. And Nico,
Oh, go ahead. Keep going, Katie.
I was just hoping we could just like, and Nico, if you wanted to also just introduce yourself, because I think that would be, and I've been at Soteria for like 10 years and I've been involved, Soteria has been open for 10 years and I've been involved in some way with the services for 8 years, just to clarify that too.
Yeah, I've been at Soteria for 5 years, currently and recently co-directing the program, which is pretty cool. And yeah, I use they, them pronouns. I don't really feel like I have much else to add to an intro, but thanks.
Okay, well, in terms of anosognosia, in terms of that question, I've treated quite a number of people who are experiencing what's called psychosis, and every one of them could be grounded and lucid when they wanted to be, or when they had to be. Every one of them, if they were applying for welfare, they were very grounded and lucid. If they were talking to a policeman, grounded and lucid. So that's an important thing to understand, even though people may be quite, whatever you want to call it, in an extreme state, delusional, hearing voices, they can also be grounded and lucid when they want to be, which is a good thing to know.
I'm seeing a couple of questions about meds in the chat, and I kind of want to respond generally about that, if that's cool. I think I can't speak for any other Soterias. We don't, in Vermont, we don't have a programmatic agenda about medications. So anybody can come in with any relationship to meds that they have or want to have. So if somebody is currently identifying that meds are a useful tool, fantastic, keep taking meds. If somebody is currently identifying that meds are easing some of their symptoms, but they would like to not be dependent on medications, we support with that. We support with like harm reduction about coming off of psych meds. And then we're really most often, I think, supporting people who are not on medications or interested in being on medications. And I think everybody gets to have their own relationship to the clinical model of mental health crisis that they want to have. And I think that's like maybe the central feature of everything we do at Soteria is that like it is person-centered, it is defined by that person. We are always sort of free as staff of those programs to share our own perspectives about these kinds of things, but ultimately we're not here to be directive about those perspectives. I think it feels important to me that our program in Vermont is not a clinical program in and of itself. We don't have a clinical director in-house. We don't have, we have a nurse on site for like 4 hours a week, not all the time. People hold their own medications in their rooms. And like, you know, all their clinical appointments and things like that happen outside of the building. We don't use language of like patient or treatment or that kind of stuff, like, because we really as a program are trying not to be the clinical force in somebody's life. They may choose to use clinical avenues as well, but that's just like not what we're doing inside of Soteria. And I think it's really, really common, maybe most common, that people come in with some sort of medication regimen that they're dissatisfied with, and they want to make changes to that. Whether that's coming completely off of their meds or changing something, finding a lowest effective dose, etc. Just basically finding a way to like live their most uninhibited lives while also acknowledging that for some people they might experience a important and significant relief by using a certain medication for a certain amount of time. I think we do a lot of work to like also support people in understanding that like the crisis they're experiencing now is going to change over time. It's not like a fixed state. It's not like a permanent brokenness. It's not like a lot of these messages that people might get from other clinical services they participated in about like never being able to come back from crisis or always being reliant on certain kinds of supports or interventions, clinical or otherwise. I think a lot of what we do is supporting people in figuring out how to like live their lives and how to be autonomous and how to seek support where they need it, but not have their lives sort of taken over by systems that are claiming to support them or tools that are claiming to support them.
I just want to chime in too to say that I heard the word recovery a few times in this presentation already, and I think we try to be really sensitive around the word recovery, and if somebody identifies with that word, that's great. You know, I think we have people that are working there that have lived and living experience, and that is really important to name. And I think recovery implies that you have something to recover from. It's a very medical model versus social model. And I've actually had people say, you know, the only thing I've recovered from is the medical model, is the psychiatrization that I've experienced, or the, you know, the sanism that I've been told I have to like conform to. So I just want to name that in this too. And because you know, unless somebody self-identifies with the word recovery, that is not a word that we, you know, go around using.
Maybe
Okay.
it might be good if some of you could tell some stories, maybe stories that sort of demonstrate the flavor of what happens. Some kinds of things that happen in Soteria houses that maybe people might like to hear about.
I'll throw one in here. So this is early. So one of the things in San Jose, so there's just on the outside edge of San Jose is Mount Hamilton. There's it's a good high hill, and there's a observatory up on top. I believe it's run by Cal Berkeley. But it was only about a mile from the house. And so one of the most common things was to just drive up there. It's a long, probably about 10 to 13-mile drive up. You could stop along the way. There's farms, there's open land and all this. That became a major therapy. I hate the word therapy, but it was very therapeutic. And if people were in a troubled state, we'd take a ride. We'd hop in my bug or in a van and we'd just ride up the mountain. This could be at 3 in the afternoon or 3 in the morning. It didn't matter. And there was one person that at the house was always angry. She was just a classic biker type, heavy black boots, black leather all over the place, and would storm around the house, just angry as could be, playing. I think mostly was Rolling Stone Sticky Fingers as loud as she could on her stereo. We got to remember this is 70. We didn't have a lot of the stuff you guys have now. So at times I would just ask her if she wanted to go for a ride, and she'd be just this super angry state. And we'd get in my bug and we start driving up. and she'd had my radio on as loud as she could play it on the hardest rock she could find. But as we start climbing up the mountain and we're just going through this just curve after curve, she started turning it down, turning it down, turning it down, until finally she turned it off. And then the rest of the ride, she would just sit quietly and just enjoy the mountainside. That happened all the time. Other times I went up with her and 3 other girls. All of us went up. We got to it was one of my first times taking them up the mountain. We went about 2/3 of the way up, stopped at the side of the road. They wanted to get out and just sit and look over the bay. So we're up probably about 2,000 feet, and we're looking down over the whole bay area, all the lights and all that. And one of the girls sitting on the rocks just started screaming as loud as she could, just screaming. And then the one next to her started screaming. And I thought, well, this is kind of freakish and interesting at the same time. So I started screaming. And then finally the third girl started screaming. So all 4 of us there just screaming at the top of our lungs at nothing, just letting it out. We must have done that for 10 minutes. And then when we finally stopped one by one whenever we were done and just kind of relaxed, got back in the car, came back to Soteria House. There's this little all-night cafe about 2 blocks from Soteria House. I took them over there. I bought them all banana splits. And so we're sitting here at 2 in the morning, eating these banana splits. All these kids had been very stressed out prior to going up. Now all of a sudden we're in the restaurant. Everybody's stealing from each other's banana splits, just laughing and having fun. And we finally finish up. We're heading home. One of the girls asked if she could just walk the 2 blocks home. I said, sure. And you can see the difference in her persona. She had just gone from this incredibly depressed, very hurt person to now being this very reflective person. She was the one that had started the screaming. She had got so much out, and she had enjoyed the playing in the restaurant with the stealing the ice cream from each other. And now she was contemplative. She was just thinking about this whole day and who knows what else, but she wanted to be alone. And that's exactly what she needed. So the rest of us said, sure. Well, I drove the rest home. We waited for her to come in and make sure she was okay. And each of us had our own different experience, but that kind of stuff would be repeated constantly. I must have made 50, 60 trips up that mountain with different people. Each time was incredibly rewarding. There was never once was there a negative trip of climbing up that mountain, because it pulled you away, put you out to nature. Another girl she would love to chase the deer. We'd find a meadow, there'd be some deer out there, and she would just laugh and chase the deer. And they would just move a little bit away and then come back. So that's what, not treating it as an illness, not treating it as something wrong with you. We're just saying, what can I do? What can we do together? And that is an entirely different response to schizophrenia than saying, you are ill, there is something wrong with you, you need to get better. I mean, those are just categorically opposite kinds of responses. And I think that even though I'm listening and I hear each one of our Soteria houses structurally are different and do things different. And like Nico saying, we don't do therapy, but we provide something that's very therapeutic. And that, I think, is the difference. And the fact that each house is different means it's not following a rigid format that it has to be in order to be called Soteria. As long as you are treating human beings as human beings, I think you're qualifying. So thanks.
Yeah, I want to maybe bring another example in. I'm really oriented around meaning making in this work. Of course, my agenda about meaning making wouldn't supersede a person in the program's desire to make meaning of their experience, but it's just sort of how my brain is oriented. And so I often find myself being like someone who's reflecting what I think might be patterns or what somebody might be trying to communicate through words that don't on their surface immediately make sense to me. So there's an example of an individual, like young Black man who was having this experience of like sort of simultaneously being on a reality show and also being tracked by the FBI, this sort of like coming together experience. And we were being with him. That's like the approach we use, is being with, basically accompanying people through whatever experience they're having. So we're going around town, and he was kind of just kind of any community member who he would walk past might become someone that he would direct some anger or frustration about racism towards. And sometimes those people would get really, really agitated with him, and he wasn't necessarily in a place where he could directly communicate with them about the things that they were saying. So then it became sort of it felt like it was my role to be able to say like, hey, I don't know if you're noticing that this person seems like they're like gearing up to punch you right now. Like they're getting really angry. Are you opting into that? And he might be like, oh, I actually really didn't notice that. Let's get out of this situation. And so there were a lot of things like that happened over time, in which like through our sort of trusting relationship, I was able to be like a second set of sensory information that I could offer, and then he could make choices based on what I was offering. So I was never saying like, stop doing that because you're putting yourself at risk or whatever. But I could say, I'm seeing what seems like a risk to me. How are you navigating that risk? And then he'd be able to speak to it. And then we were kind of in that dynamic for, I can't remember, maybe it was like a month. And then after that, we were able to have some really cool conversations where I was like, here's the kind of patterns that I was thinking I was observing over time. And I'm wondering if this is the meaning that you might make out of the situation. And we ended up kind of arriving at a narrative that, like, the reality of growing up as an adopted Black child in Vermont, where it's a very white place to be, like, became this sort of surveillance narrative based on an actual experience of people's eyes being on you all the time as a child and feeling like an other as a child, and as an adult. And it was a really cool experience for me. And also I think for him, he was able to say like, he couldn't have necessarily made that meaning without observation from trusted other people, because he didn't remember that much about the experience after he was kind of on the other side of it. That feels like a really kind of quintessential example of what we're doing at Soteria to me, and I think about it a lot.
I'd like to jump in, Nicola, a very similar kind of thing that I think, I don't know what percentage, but a very high percentage of communication is in metaphor, especially within these programs. Things are being put into a safe metaphor as opposed to being straightforward. So the other example I have is when I came back, I was helping to start dialysis, and I came back to visit at Soteria, and I was sitting in the kitchen at the table in the kitchens where we always were. That I was sitting next to him, and neither one of us were saying anything. I was just visiting. We were there being quietly, but the program psychiatrist and a graduate student from California School of Professional Psychology who was volunteering there were sitting at the other end of the table talking. And I realized all of a sudden they were talking about who I was sitting with, the guy I was sitting with. And they were talking about him clinically as a case study. And at one point, he just looked at me and he said, and then he points to the refrigerator and he says, they're trying to poison me. The refrigerator is full of poison. And I was quite surprised. I just looked at him and I said, they're trying to poison you. He says, yes, they're killing me. Now, you could either immediately say, well, this person is schizophrenic and this is a definite sign that he's paranoid. You just take that and label him, put him in the box, and there's proof that he's paranoid schizophrenic. Or you can look at the context of what's happening right then and there, and you can hear the metaphor that he's talking about. So here you have, less than 5 feet away from him, two authoritative figures. One's a graduate level psychology student, the other is a experienced psychiatrist. And they're talking about him in the third person, in his presence. And they're talking about him as if he were a case study in a book. To him, that feels like death. He doesn't exist as a person anymore. And so what does he say? They're killing me. They're taking away my life. Now, all you have to do is hear that for what it is the metaphor, not take it as some literal statement. And so I said to him, I said it fairly loud so they would hear. I said, so you think, Bob, that they're talking about you is making you be less than you are? And he said, and he just got very excited. I said, yes. Fortunately, the psychiatrist, who was a good friend of mine anyway, was paying attention, and he heard that. And it hit home what he was doing. He immediately got up from the table, his end of the table, came over, sat down next to Bob and said, I am so sorry. I apologize. I got all caught up in just talking in my head, and I did not mean to be so insulting to you. And you could, the relaxation in Bob, his reconnection with the psychiatrist, all having to do with accepting what was happening right then and there, putting it in a framework that was understandable to everybody. So, Nico, I agree with you completely. You take what's going on in the moment and address it for what it is, not for what intellectually tells you it must be. But as long as you're seeing the person as a person, you're not going to put them in a box. You're going to look who, and that I think is maybe the key thing, I think, in all these houses. I'm going to throw this in very quickly, is the ability to empathize, to feel what the person you're talking to is feeling. Not just sympathize, but empathize. And I think that is a crucial aspect to every other activity within the Soteria program, being with whatever it might be, the ability for people to empathize with people in pain. Okay.
So I was in thank you, Jean and Nico. I was in a state hospital meeting one time. So we would visit people in the state hospital, possible new referral folks being referred. And so I went to, there's a big meeting with the social workers and somebody from the floor staff, a family member, and this was a high profile client. So the actual executive director of the hospital was sitting at the head of the table. And the person, the so-called patient at the hospital, who we were coming to meet with to see if she wanted to come to Soteria House, was just sitting there. And it was the bizarrest thing I've ever seen, but I think it happens often, is this person sitting at the table and everybody's talking about her as if she wasn't there, instead of saying, what do you want? Right? So at some point I said, what would you like to have happen? And she said, I need some new underwear. I'm sick of wearing this state, granny panty underwear. And she said, because how will I ever meet people on the outside and have a relationship if I'm in like the state panties? And which is actually probably true, but I said, oh, it sounds like you're looking for a relationship, because that's really what she was saying. How am I going to get him? But instead, they kept talking about her in front of her. So she stood up on the chair. And honestly, I was so impressed with her. She stood up on the chair, made herself as like taut as a board, and then just leaned over. And she's just saying, like, I'm not gonna carry on this level anymore. And you know, I wanted to like applaud her, but the state hospital CEO says, he said, see, I told you she's delusional. And it's so, and that's the difference between a Soteria and, you know, the more conventional system. Although I hope that one of these days the Soteria type approaches and the other ones, there's a whole bunch of them out there, this is not the only one, become a part of the conventional system. But my fear around that is that it'll get changed into something that it's not meant to be. And by the way, you talk about people screaming. That was pretty common at our Soteria house. We had people screaming. And one time they called me up. I wasn't actually at the house, but there was something going on and somebody was screaming. And I had this dog that actually grew up in Soteria house. So everybody knew the dog, but the dog and I were at home, but I'm on the phone and the dog was sitting next to me, could hear the screaming and started howling, like just howling, like joined in with the screaming. And then everybody at the house, because they had us on speakerphone, and everybody at the house just started howling. And then I get this call. I get a call from one of the neighbors who actually worked for us. And she said, Susan, you better get over here. They're all howling. They're like howling. I don't know what to do. I said, I'm on the phone with them. They're howling because my dog is howling. But, you know, but you just kind of, it's the term that people use, but like every type of approach has its own jargon. So one of the jargon, Soteria jargon, is being with. So instead of doing to, being with. So you join with the person, I mean, in a safe way, not a dangerous way, obviously, but in a safe way, in a non-judgmental way. And people just kind of walk through it. I've seen it over and over again. So just to give you, we're trying to give you a flavor, I think, of what happens in the Soteria houses. And the question people used to ask me is, especially funders, well, what is the program? And I'd be like, the program is no program, but you know, funders don't like to hear that.
Yeah, I think something interesting about it is that it's not clinical, but it's a treatment, and so it's hard. That's a tightrope, you know. I call it a treatment. Now, I know people don't like to use the word treatment, but well, the reason I call it a treatment is because this is exactly what people need, or some people need, to be able to, and how would I say it, to be able to live more the way they want to live, maybe, or do what they want to do in their life and move forward in their life. This is how, it seems to me like a good way of helping people move forward in their life, however that means, whatever that means. So it's really strange. It's not clinical, but it's a form of treatment. And I sold it that way to the state of New Mexico, and they eventually bought it. It took a while, but they eventually bought it. And one other point, one of the things that's happening in Europe is that there are hospitals in Europe that are turning wards. They'll turn a ward into a Soteria approach. And I don't know how that's going, but I'm part of a group, an international group that's promoting Soteria houses, and that is happening in Europe. There are 3 hospitals in Europe that are introducing a Soteria approach into the hospital.
Thank you all so much. This is just incredibly powerful, and I really just appreciate how much wisdom and expertise there is in this panel. If it's okay we have a lot of really positive feedback, and we have a lot of really great questions. So if it's okay to introduce a question, we have, my apologies. We have one question asking, or a few people asking how they can start a Soteria in their area. If you have recommendations for how that could be done, and what funding could look like. And we have a few people looking to start Soterias in a few different places. We have Colorado, Toronto. So any suggestions that you all have, please feel free to share.
So the first thing I would say is, each of us who've been involved with Soteria houses had different startups and different funding. So the California, Jean can speak better to that. The first one was a research project, so it was research funds. And Vermont, correct me if I'm wrong, but Vermont closed the state hospital after there was a major storm, and it washed into the river or something. I love this story because I always say this Vermont Soteria House started as an act of God. And instead of putting that funding back into another state hospital, they used it for more community oriented services. And Pathways to Housing, which was a housing organization, got the funding to open a Soteria house. And by the way, you guys maybe don't know this, but I helped Samson Barris way back write the proposal that helped to fund the Soteria Vermont. But if I'm incorrect, if I'm not remembering my history correctly, but that's what I know. And then in New Mexico, and Al can speak more to this than I, but in New Mexico, there was a grassroots group that's been working for a number of years that Al, thank you very much, pretty much was the motivator and spearheaded, and was able to get some funding through the legislature. The Alaska Soteria House was unique in startup and funding. First of all, there was a public defense attorney who was also had a lot of motivation and to be involved in mental health issues, helped establish. So there's this thing called the Mental Health Trust. So he sued the state and got this money in a trust, and that trust funded the Alaska Soteria House. So if I'm not remembering my history correctly on this, and as Al said, Israel's just adopted it into their mental health system, their behavioral health system, and they're funding it through their system. And who funds Burn? Do you know, Al?
I don't know who funds Burn. What happened in Israel was a psychiatrist named Pesach Lichtenberg was talking to the Ministry of Health about it, but they didn't do anything, right? He talked to them 2 or 3 years and nothing happening. And finally, he got money from a foundation and started one, and then was able to demonstrate the effectiveness of it. And then the Ministry of Health saw and said, okay, fine, we'll do it. Katie, you can say something about what happened in Vermont, but let me say something about Vermont too. And I think this is true of all of the Soteria houses, is that people started talking about them years before they were created. And so in Alaska, it was a lawyer named Jim Gottstein, who he started talking about this years before it was created. In Vermont, I know that there was talk about doing something different than the conventional system, because I went up there about 6 years before Soteria Vermont started, maybe more than that. And the Ethan Allen Institute, led by a guy, they were having workshops. There were groups of survivors who were concerned about what was going on. So there was talk, and I started talking about it in Las Cruces 15 years ago, and finally got a group together. And we've been working on it for 5 years. So for those of you who want to start one, one of the interesting facts is that all the ones in the United States have been funded by public funds. The one in Original House, federal funds, Soteria Alaska, state funds, and the trust fund. Soteria Vermont legislature has appropriated money every year for it. So it's a matter of talking to legislators, finding some champion legislators, going to interim committee meetings, going to committee meetings of the legislature, and talking about, hey, listen, you know, the recovery rate. Okay, you don't like the word, but so the recovery rate from psychosis is less than 10% using the conventional treatment, less than 15%. We got to do better than that. Let's do better. And here's one way of doing better. And talking to legislators about that, talking to city council people, county commissioners, behavioral health people. We were fortunate because our local behavioral health collaborative developed a strategic plan. And we became part of that effort. And Soteria Las Cruces became one of the game-changing strategies in the strategic plan. So we could say our community wants this. So this is, I think this is the way you do it. You build up support, and it's kind of a slow process. And but as far as I know, in the United States, it's been with public money. Public money. One more word: Medicaid spends billions of dollars on behavioral health, quote unquote, and most of it, none of it is spent on Soteria houses, or very little, right? So, you know, there are resources out there that can be used. Other
I just wanna
ideas?
hop and say,
Go ahead,
I gotta
Katie.
get going. So thanks, everyone.
Okay, thank you,
Nico,
Nico.
Thank you.
Great.
Thank you,
Great
Nico.
hearing from you.
I'll just
I'm
put
going to follow through on. Oh, go ahead, Susan.
I was just gonna put in the chat here just what our legislation actually says for folks that are interested. So this is the formal legislation that allowed us to actually fund Soteria, and Soteria is fully funded as a grant through the Department of Mental Health. So that's, I would really, if people are considering starting Soterias, I think having it fully funded instead of needing to bill for services has been really critical in allowing us to adhere to the model as much as we've been able to. We don't have to diagnose anybody unless they want to meet with a provider and get a diagnosis. And that's been really critical to like our intake process as well. And we're licensed through the state of Vermont as a therapeutic community residence. So any program in Vermont that is serving over 2 people needs to be licensed. So that's, you can actually look that up online too, like the TCR regulations that we're obligated to follow. I just want folks to also know that I'm supporting in the oversight of our new peer respite as well. So we actually have foundation funding for a 2-year pilot project for respite in Burlington, Vermont. Well, it's a little outside of Burlington. And we're actually doing a formal research study with HSRI on that. And I'm super excited for those of you that are interested in maybe opening respites or Soteria houses. Like, we're going to have some more data within the next year or so, hopefully showing how effective peer respites are as well. There's a lot of commonalities, I think, in some of it, but it's also very distinctive.
Okay, so I just want to also follow up on this with what Al was saying, using the word treatment. You need to use 2 different words depending on who you're talking to. I mean, you have to address your audience in words that they understand within a framework that they're coming from, their context. So I saw someone in here on the chat talking about they liked all the jargon words like being with and all that, and they didn't see it as jargon, they saw it as existential. But that's who they are. So that's they're the audience that's hearing that. If you're talking to legislators and politicians, they want to hear things like outcome, treatment outcome, cost effectiveness, things like that. So you have to take what you're doing, even though it's not a treatment program in and of itself, and you have to frame it as such. Otherwise, you can't just tell them, well, we just hang out with people. You know, we just let them be what they are and make sure they're safe, because you're never going to get funding doing that. They're going to say, put down the marijuana and move on to something else. So you're always, and that's what's happening within the house too. Every time you're talking to someone within the house, you're paying attention to the context. Who's the individual you're talking to? What are their words? What are their language? What is their world? And that's where I'm going back again to empathy, where you empathize with who people are, whether they're legislatures or governors or congressmen, or the person at the kitchen table across from you that has been diagnosed. You're constantly entering their world, and that's what being with. You're entering their world and you're responding to them in their world, whether or not they're a patient, a resident, or a politician, or a philanthropist. You have to be able to go into their world. That's all.
One of the skills that we always said that was like critical to doing this work was we had to be translators, like translate. And I studied journalism as an undergraduate, which I never really used, but it's been invaluable. And the most important thing I learned from that is when you're writing, really pay attention to who is your audience. Who is your audience? And speak to the audience in the language they can understand. And I'm just supporting what you're saying, Jean, I think. But I think it's critical skill.
Thank you all. Really helpful insights. And I wanted to ask another great question that we have, which is, what do you do if someone in really risky situations where someone is potentially going to harm themselves or someone else, and you feel like there is a high risk of that? How do you kind of support them in that situation while also aligning with these important Soteria values?
Nobody wants that one.
I'll
So,
start.
okay,
I'm
go
sorry,
ahead,
go, Jake.
Susan.
So there's different levels of risky situations. And I mean, one situation that I recall is I was with a guy who went outside in Alaska in the middle of the night. I can't remember if it was single digits or below zero. And, you know, I went after, I didn't chase him. I went with him basically. And I didn't have time to put proper clothing on. And I had not the best coat for that weather, because I grabbed whichever coat I could get. And he walked and walked and walked and walked. My Soteria folks like to walk. They just go out, walked and walked and walked. And I was afraid that not only he would get frostbite, but I would. And so at some point, I just appealed to his humanity. I said, look, I'm old and I'm cold. Could we please go back home? And he walked another half a block to a block. And then without saying a word, he just turned around and walked back, started heading back home. But then there's situations where, you know, because it's not a locked facility, there's situations where, you know, we had somebody actually jump out a window, but she didn't get hurt. I think she knew what she was doing, but it does go down like that sometimes. But you still, it would be a rare occasion where we would think it was risky enough that we'd have to call the police. In fact, I don't think we ever, maybe once we did. So there's different ways to kind of help, I hate the word de-escalate, but de-escalate the situation. So sometimes when people would get aggressive, if I was there, I would just sit on the floor and invite everybody to sit on the floor. So it's really hard to hit someone if you're all sitting on the floor. And so you diffuse the situation. You're all on the floor sitting in a circle. They'd have to stand up, you know. And so it feels risky, but you know, I don't know that it's any riskier than being locked up in a hospital. I mean, I'm aware of people who, you know, hung themselves in hospitals, as a matter of fact. Another guy I know set his room on fire and burnt had some severe burns. And that's like in a hospital where there's 24 hours. I mean, well, Soteria has 24 hours, but you know, you're on watch all the time. So people do what they're going to do. And I guess you have to sit good with that.
I agree. It's Soteria programs are high risk programs, almost by definition. People are coming in at high emotional states, and they're probably have been maltreated at some point and are very frightened and concerned. Another program I was in, first, I mean, where I learned how to respond was sitting again in the kitchen at Soteria. Got a phone call from someone who was going to shoot themselves. Somehow, good old 911 just sent them over to Soteria phone, and so Stan, the psychiatrist, is talking to them on the phone, and I'm just hearing his part of the conversation, and he's saying, "Oh, I see that. Oh, you have a gun, do you? Oh, was that a shot you just did? And oh, you shot the floor." So he's talking to a guy with a loaded pistol who is ready to shoot himself. But Stan is hearing that he called for help. So he immediately is talking to him, and the first thing he says to him after he shoots the floor is, "You must be very, very angry." And that's all he had to say. And the guy started talking to him about how angry he was. And Stan just kept letting him talk about how angry and what he was angry at. And again, validating him, treating him as a human being, not telling him, "Stop that immediately, or I'm going to send the police." He just let him talk about what he was so angry about. And over about a 10-minute period, got him to put the gun down, put it away from him, and gave Stan permission to call the police. Stan was not going to call them until he had permission from the guy. So I learned just by listening to one end of that conversation. So then many years, probably 5 years later, I'm in a program, and there is a guy who is 6'3", who has been lifting weights all his life because he is terrified that someone's going to hurt him. So he's a big, muscular guy. And now he's holding a large butcher knife in his hand. And he's angry at about 4 of us that are standing in the kitchen with him. So the first thing I have to realize is he is the one that's really frightened, and pay attention to that. So I say to him, you must be, I always called them by their name. I immediately wanted to always call them by their name so they know I'm talking to them and not just some patient. And so I said to him, you must really feel threatened right now. You think I'm going to hurt you. And he just acknowledged, just kind of nodded his head, yes, while he's holding this large knife. And I said, well, I'm going to back up 2 feet just to let you know I do not want to hurt you. And I'm not going to come any closer to you as long as you feel that I'm threatening to you. And we started talking that way. And each time I would make a move, I'd say, I think we're doing a little better now. And I would talk to him about what he was threatened about. And each time he would talk, he'd be a little more relaxed. And I'd say, can I take a step closer now? Do you feel a little safer? And he would say yes, and give him permission to come a little bit closer. So again, like Susan was saying, you take each situation where it is there, but there always are going to be crises, very scary crises. And that's part of what you're accepting when you start working in a program like this. But you're also accepting that these people truly do not want to hurt you. They didn't come there to hurt you. What they really want is for you not to hurt them. For you not, if someone's threatening you, chances are they think you're threatening them. And that's what you need to address constantly. So when you're in a crisis, deal with crisis as it is. It doesn't matter if it's in a hospital ward, on a street corner, or in the Soteria kitchen. And again, paying attention to context. So again, but never think that this is going to be some kind of non-crisis program. The crisis is real.
Gene, I'd like you to tell that story about when you turned up at the house and everybody was outside and somebody was.
Oh yeah, that's I figure half the people have heard this. Okay, so this is at Eminent. I'm gonna do real quick here in this one. I'm talking way too much. I'm at Eminent, so I was a program director at Eminent. I'd gone home for the weekend or whatever, and then I came back just to visit, see how they were doing early on, and the entire house is sitting in the backyard. The program director, and my grandson just showed up here. So, you want to sit here with me? Okay, you just got a sucker. Okay, good job. So I go and everybody's sitting in the backyard, and I go up to the staff member and I say, what's going on? Why are you all outside? And he said, oh, well, I'll call him Al just to compliment you, Al. He said, Al's in the house and he's terrorizing everyone. And so I brought everybody outside because he's threatening and terrorizing everyone. And my first thought was, this is not what we're about. You can't abandon someone because you're frightened. That's absolutely contrary to what this is all about. So I immediately went in the house and I went into and Al was sitting in the chair in the living room. And he was again, another big guy. And he looked scary because he had burned his hair off. So he was very scarred and his face looked scary. And he's rocking back and forth in the chair very hard in this chair, just making a noise with a rocking chair, just ceaselessly. I went in and immediately sat down next to him, in the chair next to him. But before I say anything, I have to realize I need to know what's going on with me before I can figure out what's happening to him. And what's going on with me is I'm terrified. Just the way the staff member outside said he was terrified, but he put it on Al that Al was terrorizing him. I'm feeling terrified, but I don't feel that Al is terrorizing me. That's the difference. It's acknowledging how you feel, what's going on with you, and owning it. Don't throw it back on someone else that they're doing it to you. Own your own feelings. So I'm feeling very terrified, and I don't know what to say to this guy. So he's rocking back and forth, and finally I just say, wow, it is really scary in this room. And he immediately just stopped. And he looked at me and he said, do you feel that too? And I said, yes, I'm really frightened. He says, I am too. And so then we just started talking about how we were feeling and the fact that we were able to talk to each other. The fear went down to pretty much zero. And all of a sudden we had a relationship again. So the key to that is what I said is don't put it on the other person to who you are and what you're feeling. Own your own feelings. And I think I see Katie nodding. So she's had this experience within Soteria houses. You have to endure your own feelings. That's one of I think the major curses and the major blessings of a Soteria program is, it doesn't matter if you're the director, a staff, or a volunteer, you're going to have to face your own stuff. You're going to have to face your own process, your own fears, and your own development. And you acknowledge it always to yourself. This is my doing. This is my feelings. And I think that is part of what the great attractions of Soteria is to staff and volunteers is you find a road out of your own nonsense by acknowledging it. Okay.
Katie.
Yeah, I'll chime in because so it's at Pathways Vermont, but also like in Soteria is one of our programs there, but all of Pathways Vermont is trained in intentional peer support, or IPS, which is kind of I think Eugene, you spoke really eloquently to some of those skills that we learn in intentional peer support. So we talk a lot about mutuality and like finding a way to express our experience within, Soteria and what's going on for others. We also talk about crisis as opportunity. I think a lot of the time, folks that are in non-consensus reality states, we assume some kind of fragility that they might be experiencing, that they can't hear how we're also experiencing something. And we really don't want to come from a place of fear. So we talk about that a lot, like owning our own fear, like what is coming up for us? How is this our experience, not something we're projecting onto others? And we also talk a lot about the dignity of risk. And I think that that's, we really want to support people with having as much autonomy and as much dignity within their experience as possible. And that does take like a level of risk. I think this kind of question segued from just like, how do we support people if there's like this bigger concern? And, within Soteria, because we're funded by the Department of Mental Health, because we're licensed as a therapeutic community residence, we do have certain standards that we have to adhere to. So like one example I'll just give you that's pretty, I think, unique for us is that everybody that is in the program is deemed like a quote unquote vulnerable adult by the state of Vermont. So if we don't have track of somebody for 24 hours, we have to file a missing persons report with the police. We have had to do that, but it hasn't actually ever ended up turning out to be a negative experience for us. We've been able to find the person and collaborate with them more directly. But there are certain situations where our hand is kind of forced because of our funding, because of our regulations, where we do have to include the police, but we do it as, you know, as like, we obviously don't go that way unless we absolutely have to. But I think the framework that we come from of treating humans with dignity and respect is like just really important, and not coming from a place of fear. I really do feel like crisis is opportunity for most people I've worked with. And, you know, not trying to contain people, but trying to allow themselves, to be free, to work through that experience as much as possible.
No, I agree, Katie, that it's nice to hear that there's now trainings for things that there didn't used to be training for, and there's terminologies for them that I have to keep looking for the right word. But I love the idea that crisis is opportunity, because what we're talking about, and what I partly a major part to me for madness is it is a process. It is a moving process that you're moving forward in. And part of that is it's coming from a crisis somewhere along the way, a traumatic event or a traumatic life crisis, but you're processing through it. So that's the difference, that you seeing it as an opportunity, I think, is a wonderful point of view. I really appreciate using those words. So, okay, thank you.
I just saw a question about, I haven't been tracking the questions, but this one struck me about, are you in neighborhoods? How do you mitigate being in the neighborhood? And I'm not sure if I'm capturing it correctly, but we very much were. And when we were first, before we opened Soteria, Alaska, I went to lots of community meetings, and basically I canvassed the neighborhood and introduced myself and some other people we worked with. And so we didn't have residents yet, we hadn't opened yet, but we felt that we should let them know. And then afterwards, I was sorry I did that, because they gathered together and developed a community resistance, not in my backyard. But fortunately, the municipality said, they can't tell you. In fact, houses that are open to people with disabilities are sort of protected, so they can't do that, right? So we did, and then the truth is, the neighbors grew to really like us, because we kept up the house, we kept up the yard. Not everybody did, as part of activity around the house. We all worked we kept up we mowed the lawn, and the neighbors started to appreciate that. And but initially, they have it's got stigma attached to it, and that was the first reaction, not in my backyard. So but ultimately it sort of embraced us.
Thank
Yeah,
you so much. Yeah, I really appreciate that perspective. I am just noticing we only have a few minutes left. Thank you all so much for what you shared and for being here. And yeah, I feel so grateful for all of you and for this webinar. We do just want to make sure that we are accessible. And so I wanted to make sure to read the slides that are that you showed in the beginning. Um, and so I just want to make sure to read those out loud to be accessible to those who are listening in. Al, would you be able to pull those up, and I'll go ahead and read those out loud?
The slides, okay. Here we go. Hopefully it'll come up. Okay. Slow. My computer is very slow. Um, oh God.
It's loading, I think.
Yeah, it's so slow. Oh, okay. Here you go. That's what first one.
Um, it's still not sharing on my end, but I guess it's loading. Oh yeah, here we go. So as I think this is a great summary to end with. So this Soteria approach is a small home-like residence in the community. It's a safe, supportive, and affirming environment. The average length of stay is 3 to 6 months. Residents participate in house upkeep, cooking, housekeeping, and gardening. Family and friends and others in the community are welcome. Community inclusivity with Soteria staff supports. Being with rather than doing to. Treatment-based and supportive relationships. Medication may be used, but is not the primary mode of treatment. 24/7 coverage, and graduation and continuity in the community.
Okay.
In the healing process, the first stage was the break, when the patient took the initiative to make a significant contact beyond that necessary to survival, with some other member of the community. The second stage was friendship, when the patient established an interpersonal relationship with another person in which the patient saw him or herself in a partnership with that person, in a symmetrical relationship that was honest, affectionate, caring, and trusting. And the third stage was communal identification, when the patient felt a member of the Soteria family, not simply a member of the house. And then the fourth stage was extending, when the patient began to establish relationships outside of the Soteria community. And the fifth stage was network balance, when the person's support system included persons from outside Soteria as well as within Soteria. And this process is described in rich and colorful detail in Soteria Through Madness to Deliverance by Lauren Mosher and Boyce Hendricks.
That's it. Basically, that's it.
Okay. Yeah, thank you all so much. And I just appreciate what all of you shared. I just got a question about whether we'll have access to the recording, and yes, we will definitely be sending out the recording in the next week or so. So keep an eye out for it. This was such a great webinar. I did want to let you all know that starting next week, next Wednesday, we have a two-part webinar series coming up that is going to be presented by Youth Move, and it is called Understanding and Exploring Youth Peer Support Frameworks. So if you are also interested in youth peer support, in addition to this more general peer support that we're talking about, please do join us for that. And we'll be sending out an email about that right after this. So you should all get that. Thank you so much. And I'll turn it over to our panelists if you have any closing remarks or anything else that you wanted to add before we end the webinar.
Well, I want to thank Jean, Susan, and Katie, and Nico for this. It's just really terrific. You have so much to offer from your experience. And why don't each of you just say a few final words?
I just wanted to say thank you to our participants for being here and contributing and asking the really relevant questions that you ask. Thank you.
Yeah, well, I'll thank everybody. But mainly I also want to say is don't give up. Just keep on doing it. It's never going to be the primary form of dealing with mental illness in our society, but it can still be the best form. So keep on tracking. Just don't give up, you know.
Yeah,
Wow,
I'm
I
just
like you. You should be cloned.
I just want to say thank you for everyone with this interest in being here. It's really inspiring to see how many people showed up for this today and how many of you are interested in this. I wasn't very good at multitasking with reading the chat today. So I saw that there were a lot of like really director specific questions, which we get a lot of interest around all the time at Pathways. So we're actually going to be starting to do quarterly like Q&A sessions for people to come and ask questions. So I'm just going to re-put this in the chat here. If you're interested in getting kind of, we're creating a list of people that have reached out to us to kind of channel to those Q&As. So if you want to get on that list, feel free to reach out to me directly and also our training team. We're in the process of scheduling those.
Great. And I want to thank National Empowerment Center for doing this and for all the work that National Empowerment Center does. And there's a lot of it. I know ECPR and you're just a wonderful organization, and actually still supported by the federal government, which is really wonderful. And I'd also like to encourage any of you who want to start a Soteria house, please do it. Start working on it. Get together, get some people together, get a group together, start talking to people, and start making it happen in your community. We need many more of these. We just need many more of them. There should be one of these in every city of 50,000 people or more in this country. We should have thousands and thousands of them. Someone had a question about where in Europe, Germany and in Belgium, there are hospitals that are turning wards into Soteria houses. I'm going to I'll put my email, and if you want to, I'll put my email in the chat.
Can you also say what it is?
My email is agalves2003@comcast.net.
Thank you.
agalves2003 and I can get you in touch with other people who are doing this, who are doing it.
Has anyone ever tried to start a Soteria house here in Pittsburgh? That is Pittsburgh, Pennsylvania.
No, as far as I know, not. There is a peer-run crisis respite house called the Leaves. Is that what it's called? What's it called, Susan?
Fern.
The Ferns. It's near Philadelphia.
Oh,
It's a crisis
okay.
respite house. The Ferns. A woman named Kathy Laws is behind it. You can put the Ferns in a search engine and get in touch with her.
Thank you so much. We do need to go ahead and wrap up, but these are great questions. I love seeing how much interest there is in this topic. Yeah, so please do feel free to email additional questions. And thank you all again. And hope we'll see you next week for our next webinar. Bye, everyone.
Thank you, Shira.
Bye.